Welcome to Chet Talks. Our next guest is a physician, an entrepreneur, an investor, and a man clearly ahead of his time. Dr. Dan Gebremedhin wears many hats. He's a practicing internist at the Massachusetts General Hospital. He previously co-founded two businesses, one in electronic health records and one with online medical education. Clearly saw the future at an early stage. He's also served as a senior health policy advisor for both Massachusetts Governor Charlie Baker and Congressman Joseph Kennedy. He's now a partner at Flair Capital. Flair Capital provides capital and partnership with creative entrepreneurs to reinvent the business of healthcare. Few are better positioned to help Flair Capital than Dan. He previously served as the medical director at the Harvard Pilgrim Health Plan. He graduated with honors from University of California, San Diego, summa cum laude from Morehouse School of Medicine, and completed his internal medicine residency at the Massachusetts General Hospital. In his spare time, Dan earned an MBA from the Harvard Business School. Dan, welcome to Chet Talks.
Thanks for having me, Ray. I appreciate it.
So in April, at the height of the COVID-19 pandemic, at least in the United States, you and your colleagues at Flair Capital held your annual meeting, I think virtually. What did you discuss?
Yeah, no, thanks for mentioning that. I think like most funds, we have our own annual shareholder meeting where, the investors that invest in our fund, kind of get an update and a report, our annual meeting normally is in April, and, we were struggling with, the coronavirus epidemic, as many of us still are. And so we held a virtual meeting. We had a number of speakers that spoke to what was happening, in the nation, from an economic perspective, and then specifically from a digital health and healthcare perspective. And so, it was a somber meeting. I think there was still a lot of uncertainty in the market broadly. And so, I think part of it was talking about the future, but a lot of it was talking about what are we going to do now to help our companies kind of manage through a significant downturn, in the economy, as well as a lot of shifting, kind of demographics and shifting practices on how do you maintain, a healthcare business in a challenging time.
What were some of your concerns when you held that meeting?
Well, business as usual, in the healthcare industry, kind of stopped overnight, with many individuals not going to brick and mortar facilities for healthcare. And so if you were operating a brick and mortar facility, if you had a clinic of sorts, or you were selling into, brick and mortar facilities, clinics and hospitals, overnight, I think purchasing behavior is how I might describe it. I think has dramatically reduced, kind of patients are no longer coming to their, traditional clinicians in ways that they had to in the past. And so, the profit and loss statements of those organizations are decreased, as well as those vendors who are selling into those customers overnight, essentially paused. And, probably 3 to 4 months into the pandemic, we're starting to see, resurgence of, historical volumes, but they're still significantly below the patient volume that we had seen prior to that.
So where do you see some opportunities? Yesterday, Rock Health announced that there was more venture capital funding in digital health in the first half of 2020 than ever before, at $5.4 billion, up 20% from last year. Clearly, investors are seeing some opportunities. Where do you see them?
Yeah, it's interesting, with respect to that Rock Health report. I think what you saw is essentially a pause, kind of in March and April. And then, again, a resurgence, as I flagged earlier, as we're getting more certainty around how we plan to come out of the pandemic, what the new normal looks like, kind of in May. And I would say that there are a few areas because of the pandemic that I think universally people are seeing as becoming, kind of quite attractive, must-have technologies and services. And so I think if you look at the funding, a lot of the funding ties to those areas. So again, this concept of telehealth or virtual care, Amwell raised an extremely large, nearly $200 million round, kind of in the spring. Things like home care, again, bringing care to populations that for one reason or another can't rely on virtual care alone. Dispatch Health, kind of on-demand home-based care delivery organization, raised over $100 million. And then behavioral health, as, society struggles with a lot of the stressors, as a consequence of the pandemic. But you could argue that already our behavioral health system was stretched quite thin with real challenges with access. And so Mindstrong, for example, raised over $100 million in that behavioral health section.
So let's take a deeper dive on some of those. We had Dr. Cynthia Horner speak from Amwell a couple months ago. They're indicated that they're going to file for an initial public offering. Your thoughts on Amwell?
Again, Amwell is one of the, extremely large, kind of legacy players in telehealth. There's kind of that, the quasi big four or big three, led by Teladoc, which has already gone public and has done extremely well in the public markets. Amwell, Doctor on Demand, MD Live might be the other big one that I would think about. But they've been in the market, for, probably over a decade, kind of as pioneers. And I would argue that historically, telehealth had low utilization, right? You'd hear many stories and read many reports of, single digit utilization numbers. So less than 10% of a covered benefit population using telehealth. Well, in the time of pandemic, that number has gone up 4x, right? You now have around 40% or so of populations, at least in the acute phase, using historical direct-to-consumer telehealth. And that has definitely played to the strengths of, the Amwells as well as the other companies that I'd mentioned.
So just to give you a flavor, at the University of Rochester pre-COVID, I think less than 1% of our visits were via telehealth and peaked at 60%. The majority of visits happening at a major medical center were via telemedicine. Can you tell us a little bit about virtual primary care?
Yeah, no, I kind of chuckle a little bit because, it all depends on who you talk to. You're going to get a different definition of virtual primary care. Many of the legacy telehealth providers have rebranded what they do as virtual primary care, as well as a number of new entrants have entered into the space and are defining, their own version of virtual primary care. And, it's actually probably not a well-kept secret. We actually haven't publicly announced it. So this is, a release on, the Chet Talks. We invested in a virtual primary care company in February or so of this year, but we'll announce a little bit later, a company called Eden Health that essentially tries to virtualize the traditional primary care experience. And so what do I mean by the traditional primary care experience? You have a longitudinal relationship with a care team. So you kind of have the same PCP, you have the same, primary care provider, you have the same, ancillary care providers, whether they be nurse practitioners, PAs, potentially, social workers or healthcare navigators, some behavioral health clinicians. And so that's kind of what, when you think about true virtual primary care, it's the same care team, a longitudinal care experience that I think is modeled after the patient-centered medical home, which is a long time, kind of quality first movement in the world of primary care. As opposed to what I would say traditional telehealth is, oftentimes, especially being delivered by the direct-to-consumer telehealth providers, oftentimes it's very transactional, it's very episodic, it's predominantly for urgent care. You don't expect to see the same clinician or the same care team if you have visits that are, 2 to 3 months apart. You're ultimately coming for, a quick fix for an urgent healthcare need. But you rarely ever historically have considered telehealth providers to be your medical home where you continually and longitudinally reach out to the same, care entity over time for your healthcare needs.
So I'm going to remind our listeners we're looking forward to your questions. Just put them in the Q&A spot, and we'll be sure to ask Dan those. Can you tell us a little bit more about Eden Health and how it works?
Yeah, so Eden Health is a New York-based company that focuses on employer populations. So, again, they work with employers to provide, this longitudinal primary care experience. They provide it via virtually, right, via virtual, mobile first platform, but then they also actually have near-site on-site clinics where they actually put them near or around, an employer site. And, again, when we made the investment pre-pandemic, we were quite excited about that near-site on-site employer-based business. And this concept of omni-channel access. If you need to go into a physical clinic site, you kind of get that in-person care, but you have 24/7 access in an asynchronous way to access healthcare. But post-COVID, 90+% of all interactions that Eden is actually seeing are now virtual, up from where 2/3 of their actions were historically virtual. And so again, I think it definitely played to their strengths. You're hearing more about virtual primary care and virtual care more broadly. And so Eden I think is kind of bombarded right now with interest, not just from employers, but then also actors that are stakeholders within the kind of the employer coverage benefit delivery cycle. So carriers, brokers, TPAs are all interested because they're looking to bring great virtual on-demand solutions to their employer bases.
Can you tell us a little bit about who the clinicians are for Eden Healthcare? You can imagine your expectations of who sees you for a sprained ankle or a sore throat might be a little bit different than who's going to see you for the next 5 to 10 years for managing your healthcare.
Yeah, it's interesting. In our diligence, we found that, kind of professional populations, that oftentimes kind of tend to skew younger than, say, your traditional kind of chronic, kind of healthcare populations that have chronic medical disease. Roughly 40% of these populations don't necessarily have a PCP today. And that if a primary care solution was delivered by their employer, it was convenient, accessible, would provide quality care in a digital first, kind of native experience, that there would be significant demand and uptake. And so for roughly, again, 40 to 50% of the populations that Eden serves, they are their primary care of record. But to your point, if you already have a great PCP relationship, but you just needed a, kind of, urgent, kind of on-demand, kind of healthcare transaction, you can kind of come to Eden and obtain that. But ultimately, you'll have that same care team that delivers care to you over time.
And who are their doctors? Do they partner with medical centers? Do they hire their own doctors?
Yeah, no, it's a great question. So Eden is a full stack, vertically integrated, kind of, deliverer of care, so provider of care. So they employ their own clinicians, they employ their own doctors, they employ their own, kind of, mid-level, physician extenders, nurse practitioners, physician's assistants, behavioral health clinicians. They also provide navigation services. So they have healthcare navigators on the team who help people execute, their administrative transactions, pay for bills, make appointments. So it's all full stack.
And then does Eden Health, do they sell to employers and do they charge employers X dollars per member per month? Is that their revenue model?
Yeah, essentially. Essentially, they charge employers an administrative fee per employee per month, but then because they're performing a lot of, traditionally covered healthcare transactions, they'll also bill the carrier, the insurance company, for those transactions as well.
So we talked a little bit about telemedicine, how it's expanded its reach from just episodic care, sore throats, earaches, to primary care. Another big trend that you've discussed is the migration of care away from hospitals and clinics to homes and mobile devices. Can you give some examples of companies that are trying to bring care into the home?
Yeah, we had flagged one earlier called Dispatch Health that raised a large round. Contessa, which is doing hospital in the home, so actually providing acute care, acute level care that normally would have been taking place in the hospital. But because it's lower cost, it can be higher quality and higher satisfaction, specifically for the patient. And then now in the world of COVID, it's just not safe oftentimes to kind of get care at the hospital, given the risk of coronavirus if you don't need to undergo that risk. So that's also led to a lot of tailwinds in hospital and the home. We have a business called Somatis, focused on kidney care populations, also raised a large round, over $60 million. And they focus on providing, again, world-class coordinated longitudinal care for populations struggling with kidney disease. So patients with end-stage kidney disease on dialysis, as well as patients with chronic kidney disease, and oftentimes have a number of comorbidities and just more medically complex than the regular population. Somatis will provide home-based care, longitudinal care management, as well as managing a lot of the, the social barriers to access for care.
So you mentioned hospital at home. We had Dr. Bruce Lepp on a previous Chet Talk. All of our Chet Talks are now on a website, chettalks.org. So we've talked now about telemedicine taking over episodic care, primary care, chronic care for somatis and chronic kidney disease, and even acute level care in the hospital level care. One other area that you mentioned a little bit is mental health. You want to talk anything more about that?
Yeah, I mean, I think that our behavioral health system prior to COVID, was struggling with solving the access problem. I think there have been a lot of tailwinds, given that, we, broadly speaking, people could not visit, clinicians for the longest time. And so CMS has definitely relaxed a lot of the telehealth and reimbursement barriers to providing telehealth. And so the behavioral health system, I think broadly has benefited from that. I think we're going to continue to have challenges as meeting the needs of a higher, kind of populations that need a higher level of care. So patients with serious mental illness. So populations that are struggling with substance use disorder, populations that are struggling with suicidal ideation, as well as, kind of the higher needs population. So again, telehealth alone, I think won't be enough to solve that. I think we'll have to come up with more innovative solutions there.
So when you were at Harvard Business School, you probably had the privilege of listening to Professor Clayton Christensen talk about the Innovators Dilemma and talk about disruptive innovation. It sounds like we're seeing a lot of this right now. A lot of our listeners, including me, hang out in medical centers, major medical centers. Should we be concerned about all this disruption?
I think you have to co-opt it. You can be worried and sit on the sidelines, but I really do believe that, kind of legacy healthcare providers need to see what's happening and play a role. Otherwise, they will be disrupted, candidly.
Do you want to amplify?
I mean, I might clarify. I mean, a great example is what's happening with hospitals today, right? Large, hospital-based health systems that have been so focused on inpatient care. Now, I would argue that, coronavirus didn't necessarily create any new opportunities. I think it really just amplified and hastened and served as a catalyst for things that were already happening. So we were already moving care away from large kind of hospital dominant systems back into the community, whether in outpatient care or in the home. I think, coronavirus really, dramatically flipped that, on its head overnight, where it became disadvantageous to get care in a hospital. I mean, you've seen a number of reports that are showing that populations are staying at home and suffering, significant adverse, kind of complications and events. People are having heart attacks and minor strokes at home in silence because they're so afraid to get care, in the hospital. And I think, unfortunately, what's going to happen, at least from the hospital's perspective, is there's going to be some learned behavior. Payers, as well as other vendors, are going to move in and provide care in the home to these populations. I anticipate if it's done appropriately and done well, the patients will like that experience and will look to, re-engage with these providers if they have healthcare needs in the future, even after we've passed, kind of the pandemic. And so, again, I would charge, large hospital-based health systems to see what's happening in the market and co-opt a lot of that change, be the hospital and the home provider that disrupts your traditional inpatient, kind of service line, because, these are all, I think changes that were happening before, But now with COVID, it's a crisis. And, again, there's that famous quote, you never want to waste a crisis. And I think that's happening right now. We're having to redraw into the lines of our healthcare system for sure.
Do you see opportunities for medical centers to co-opt by partnering with some of these rising companies, or would you see them creating their own service offerings independent of these companies?
Yeah, it's a fair question. And, again, I think every system is going to be a case by case, scenario based on the population they serve, based on, kind of the payer landscape in their respective markets and what the competitive landscape looks like in each of those markets. In general, I think as venture capitalists, we have a bias towards partnering. We believe, having, focused, dedicated entities working on a really, really important problem are going to hire better, are going to have better technology, are going to have, oftentimes more capital to invest, in one service offering or one product offering per se. And that, large, incumbent, stakeholders are probably best to partner with an entity that has a best of breed service. And, whether you white label it or whether you have some sort of joint venture, or some sort of co-sale, again, we've seen that model work quite well in our portfolio. A great example is Bright Health. Bright Health was a health plan that we seeded the first capital in back in 2015. The company, has raised, hundreds of millions of dollars in capital, kind of nationwide health plan. They partner with various health systems in each market that they go into. And then I call it, they become the white labeled health plan. They become, kind of almost like the provider offered health plan in each of their markets. And they've done quite well, as opposed to, I think, a lot of historical, efforts at, true provider sponsored health plans where the health system creates their own insurance company, which I think has not worked out as well as this kind of co-opted partner JV model.
You've highlighted a lot of opportunities here. You've also, when we discussed earlier, have some concerns. One of your concerns was companies that would be selling into large major medical centers who are confronting financial crisis.
Yeah, it can't be understated how tumultuous I think the period has been for large hospital-based health systems. I think primarily because they are almost this kind of public entity, right? They're the provider of last resort for acute care, and because as a public entity, they've kind of had to provide healthcare to our population struggling with coronavirus. They've completely had to upend all of their systems. They've had often, in many cases, have had to, completely stop or slow down elective surgery volume, elective procedure volume, which are huge profit drivers for the hospital. As I flagged before, populations have completely changed how they access care, and that will also affect, these large health systems. And so, aside from being in crisis mode, I wouldn't say at this point, they're in opportunistic or aggressive mode where they're, thinking about non-core activities that are not related to coronavirus. And so, if you're a software provider or a service provider that is providing, kind of products and services to a health system today that are not directly tied to their response to COVID, it's going to be extremely challenging to gain the mind share, let alone the dollar share from the budgets, which are extremely, kind of hampered and affected by, this pandemic. Again, we've seen it in our portfolio. I think we're seeing it broadly across, the digital health landscape. And I would say it also extends to traditional outpatient providers, where that they have been dependent upon patient flow for elective or things that can be considered to be elective and non-urgent procedures. So, different specialty groups have also been affected because of the same, large macro changes.
To your point, large for-profit hospital chains have been hit hard. HCA, Hospital Corporation of America, said their stock price decreased by a third. What's your outlook for hospitals?
I think that there will naturally be some consolidation. I think prior to COVID, you had heard stories about, some hospitals running at, 60 to 70%, kind of bed capacity and bed utilization, at baseline. That is, again, it's going to drop overnight. And so I imagine there will be some consolidation. I don't think that you'll ever get rid of, the need for acute care, right? Again, you're going to do as much as you can to shift that lower site, the lower acute care to lower cost sites of care. But there's still going to be the, 70 to 80% of care that requires, a tertiary facility that requires, really focused specialty groups. And so I imagine there will be some M&A, but, again, would encourage a lot of these large, legacy historic, organizations to start to think about how care is happening in the community and how can they co-opt that care.
So pre-COVID, the number of hospital beds in the United States or admissions to hospitals has been relatively flat. And when you adjust it for population growth, has been decreasing. And that was pre-COVID. I think post-COVID, we might see even more acceleration. Another concern are nursing homes. You, Dr. Gebremedhin, serve on Governor Charlie Baker's Board of Nursing Home Administrators in Massachusetts. Up to 40% of deaths due to COVID-19 in the U.S. have occurred in nursing homes. What do you need to do better?
Yeah, no, appreciate you mentioning it. And again, I think it's, another kind of worst kept secret about the COVID crisis is that, it, kind of unfortunately disproportionately affects certain populations. The frail elder population, those populations that, minority communities, get socioeconomically kind of disenfranchised populations are also predominantly affected by the COVID pandemic. I think that at least in Massachusetts, we've moved to, dedicate, certain nursing facilities to COVID-related care. But, a lot of regions can't, or don't have the ability to do that. They're maintaining a healthcare system in real time while trying to also, kind of prepare for and defend against COVID. And so, again, I think we're getting better from, a policy perspective and protecting these populations. But because of their medical complexity, they are at the highest risk and have the highest mortality rates associated with COVID-19.
So other than separating, maybe designating COVID nursing homes and non-COVID nursing homes, what else can be done to decrease the mortality and death that's occurring in nursing homes?
Ultimately, reducing contact, right? Reducing exposure. And so, better utilizing telehealth, again, making sure that appropriate, kind of PPE and sterile procedures are taking place, but then also, leveraging, technology to ensure that this population is able to get care, but at the same time is not exposed unnecessarily to risk of contracting the infection.
I'm going to get to the questions in just a second. So if you have questions, put them in. Are nursing homes dead in the future?
Again, I don't know that you'll completely replace the need or remove the need for nursing home populations, because I think the reason why someone goes into a nursing home oftentimes is multifactorial. But I continue to see increased movement of technology and services into the home to allow people to age in place longer in home and perhaps push off the need for residency in a facility.
We like to make our guests sweat on CHED Talks. 90 degrees, but damn, we'll get them an air conditioner. We'll see if we'll give you some softballs. Matthew Bessa asked, what are the pockets of greatest return in digital health? The amount of money going in seems to be disproportionate to the size and number of exits with few IPOs and just a few small acquisitions.
Yeah, I think that's kind of been a detraction on the broader digital health boom that we've seen, that you haven't seen, a significant number of exits. Again, I would say there's a lot of capital, a lot of interest going into the system. And generally, I would say that's a good thing. I think naturally over time, you will see some digestion. Some of these companies won't be able to generate the returns, but there are a lot of big wins and a lot of big successes. You've talked a little bit about some of the digital health companies that have gone public in the recent past: Teladoc, Livongo, Progeny, One Medical, Health Catalyst. These have all been, amazing successes and great returns for early investors. And so I anticipate you'll continue to see interest and belief because there are, these extremely great big wins. But then there's also, a lot of M&A activity with, large dominant payers like Optum has been quite active in acquiring businesses. Anthem has been quite active in acquiring businesses. So I think you're still getting these wins, and so I think you'll still continue to see a lot of activity in the space.
A couple questions related to seniors. Kayuri Shaw, how much is the omni-channel presence critical, especially for senior populations? How much in-person delivery will remain critical for this group?
I think it's going to be a mix. Again, ultimately, I think in the near term, we're going to try to reduce in-person care. But over time, I think, wherever you can leverage telehealth, wherever you can leverage virtual care and asynchronous care to stretch, your healthcare workforce, I think is going to be super important. And then it's also going to be safer for these populations. Ultimately, adoption is going to be critical. And so I think technology alone may not work for some populations. You may need to have that in-person component just to maximize adoption.
Farah Siddiqui says, hi, Dan, given your background in the nursing home space, what are some of the biggest challenges that need solving in the skilled nursing facility space? What are your thoughts on the application of remote monitoring in skilled nursing facilities?
There's clearly a lot of opportunities to improve, how we deliver care in nursing homes today. If you were to ask me, I don't know that it's a single technology or a single service that's going to solve a lot of the problems that I think nursing homes have. I think a lot of it has to be the way that we reimburse the nursing home healthcare system, broadly speaking. And so I think we need to tie more payment to better outcomes. And I think if you're able to do that, you can incentivize, you can invest in world-class care for these medically frail populations that not only require this care, but they also deserve it.
Rose Maruga asked you about Eden Health, the company that does virtual primary care. Does Eden Health have the ability to integrate their data with others to ensure continuum of continuity of care across multiple clinicians?
Yes, Eden does serve as the health home for the populations that they serve. So they're oftentimes making referrals to specialists, sharing information with specialists, receiving information back from specialists, lab studies, radiological studies, other forms of diagnostic testing and communication. And then they have healthcare navigators that connect with other specialists and other, kind of administrative needs in the system. And so you kind of have to have a bi-directional, kind of two-way flow of information in order to do that.
Our good friend Rob Sheth asks, are there areas of telehealth that investors should avoid, maybe due to reimbursement or lack of approved or validated diagnostics? Cancer comes to mind. There's also been some discussion of home blood diagnostics.
I don't know that there is an area of telehealth that I would necessarily avoid. I think as venture investors, we're ultimately looking to invest in companies that have, 5 to 10x growth, over a period of years. And so I might think of that as areas where you're going to get, kind of significant growth and adoption, as well as, a significant premium. Oftentimes I think the knock on telehealth pre-COVID was, it's basic services. So if you invest in a business, you may not get a significant multiple on your capital because it's just telehealth. And so, if that telehealth is part of a broader value-based care model that is differentiated and proprietary, you may get a better return on your invested capital, given how competitive a lot of these spaces are going to become. And oftentimes when you have a lot of competition, these products tend to become commodity. You tend to get a lot of pricing pressure and a race to the bottom. And oftentimes, that, set of circumstances tends not to necessarily lead to the best return on investment.
Staying on digital medicine, Mark Boyd says, we haven't heard much about digital or telemedicine solutions for pediatric behavioral and mental health care, even though these populations are really underserved. Thoughts?
Yeah, no, it's a really great point. I think prior to COVID, we had started to see a few, digital health companies focus on pediatric behavioral health. I think historically in the later stage private equity space, kind of services for children on the autism spectrum has been quite popular. I can't say that you've seen a lot of digital health innovation in and of that space, but you're starting to kind of see it. The other thing, in that regard, the power of the families, right? Many of children who have behavioral health needs have a therapist overnight. That therapist could no longer visit with the patient. There's a big gap that the family can play a role in. And so we've seen a couple companies, Equip is one, Brightline is another, where they're trying to harness the family to, help provide therapy to the child who is struggling with a behavioral health condition.
I'm going to highlight, to see if I get this right here, our upcoming Chet Talks coming up here before we give you some closing questions. So I hope people can see that. So do you see that, Dan? Yeah, perfect. So our next Chet Talk is with Dr. Robert Califf, former FDA commissioner and professor of cardiology at Duke University and a scientific advisor at Verily Life Sciences. That'll be next week, Thursday, July 16th at 12 noon Eastern. And then the following week on Tuesday, July 21st, we'll have Dr. Charlotte Ye, who's outstanding, is the Chief Medical Officer for AARP, and I'm sure she'll have lots of thoughts about how to care for seniors. So Skip Rodenbush somehow figures out what I'm thinking about. So he's asked one question, then I got a couple follow-ups to end. Skip asks, how as a nation can we adopt the behavioral change standard to incentivize and reward individuals to comply with COVID-19 guidelines? You're a physician, you're hanging out in Boston. How do we get people motivated to follow COVID-19 guidelines so we can prevent people from getting sick?
I think it's just better messaging, candidly. I think, unfortunately, we've had a lot of mixed messages associated with the COVID pandemic, and that has not produced good results. Candidly, I don't think you need to pay people to follow COVID guidelines personally. And so I think it's better messaging from our public health officials and, and unfortunately, enforcement, right? If people are not complying with these rules, because it's safety for the entire population, it's public health. I think it's a must-have. I don't think it's a nice-to-have.
So on the public health leadership, we have national elections coming up in less than 4 months, if you can believe it, Dan. You've previously advised both Republican and Democratic candidates. What would your advice today be for improving healthcare policy going forward?
It would be to vote. I think ultimately, do your research and vote. Again, not gonna, advocate for one candidate or the other, but think that it's times like this where I think we really, kind of understand, kind of where some of our politicians lie, what the priorities are to them. And I think it's really unfortunate. I think the leadership that we've seen in a time when our nation needs it most.
Any policy recommendations you want to put out there for the candidates?
Well, again, I think that there's a lot of smart people, in the current administration who are trying to make sure that, we're doing as much as we can. And I think, interested parties who ultimately want to, assume leadership have also, kind of described a lot of robust focus on contact tracing, diagnostic testing, which I think is all super appropriate.
Well, Dan, many thanks for joining us. Dan, for those who don't know, has been a huge supporter of our efforts with our D-Health Summit for the last 3 or 4, maybe even 5 years. Has been a great and generous advisor to us, and we're delighted that you could join us on Chet Talks. Until next week, when we're speaking with the former FDA Commissioner, Dr. Robert Califf. If you want to know about digital biomarkers and Verily, if you want to ask him questions about Fitbits, their acquisition of Fitbit, or if you want to know about virtual clinical trials, Dr. Califf will be delighted to discuss those. Dan, thanks very much, and we'll see everyone back next Thursday at 12 noon Eastern.
All right. Thanks, Ray.
Thanks, Dan.